So I'm presenting hybrid coronary revascularization. I have no conflict of interest. I'm not biased toward HCR. It's basically because there are controversy about the subject. So this is the outline of my presentation. In fact, CABG is the gold standard of addressing coronary artery bypass, coronary artery disease. It has proven to improve survival, improve, let's say, improve quality of life, and it's even better than PCI in many of the patients. So and it's done in several ways. The conventional way is the standard way, and the established way of doing CABG. But there are so many other ways of dealing with doing CABGs. OpCab has been introduced probably in the last 2 decades, and many people are doing it despite the controversy about OpCab. MidCab, again, it's minimally invasive surgery, doing LEMA to LAD only through a small thoracotomy. TCAB, total endoscopic CABG. It goes hand in hand with MidCab, but unfortunately, although Dr. Shaheen presented the endostabilizer, but the company withdrew support of cardiac surgery, and I don't think they're producing any endostabilizers now. For the last probably 6 or 7 years, it's not available. So it's almost not done as TCAB, complete endoscopic. And the total minimally invasive CABG, which Dr. Shaheen already presented. And lastly, the hybrid coronary revascularization. So there are so many ways of doing CABG. It's basically because surgeons try to reduce the morbidity and mortality associated with conventional CABG. And there are so many ways of skinning a cat. When there are so many ways, it means that nothing is perfect. With CABG, especially if it's done the standard way, you have pulmonary bypass and you have the sternotomy incision. And each one contributes to the morbidity and mortality of patients. The sternotomy is a big incision. It contributes to the tissue trauma, and it has its own implications in the setting of postoperative complications. And also cardiopulmonary bypass. To avoid this, let's say, cardiopulmonary bypass, through this sternotomy, people have done OpCab, on-pump beating heart, although it's not completely avoiding bypass surgery, and cross-clamp fibrillation. And that probably reduced some of the complications associated with conventional CABG. Sternotomy, as I mentioned, mini thoracotomy reduces tissue trauma and reduces pain postoperatively, blood transfusion, and so on and so forth. To have an ideal, let's say, intervention, you need a mini thoracotomy or minimally invasive mini incision, and avoid cardiopulmonary bypass. And you cannot do this in every patient. The ideal situation is doing it hybrid. So you use the best of the two worlds, let's say. You do LEMA to LAD surgically, and then PCI to the non-LAD lesions. It's known that PCI has less procedure-related complications, but the long-term outcome is inferior to CABG in many cases. CABG has, let's say, more procedure-related complications, but it has better long-term outcome. If we bring those together with HCR, that's the people expect to have better or less procedure-related complications and better long-term outcome. And that stems from the fact that the LAD is the main blood supply that in fact makes a difference in either CABG or PCI. We normally don't operate on patients who do not have LAD disease. So the LAD supplies 50% of the myocardium, and even more if it supplies bilaterals to the other territories. And we know that LIMA is the best graft to the, and then if you put it on the LAD, which is the best coronary artery, that's what makes the difference in the long-term prognosis. We know that 10 years patency rate of LIMA is 95 to 98%. And we know that SVG does not last long, and the long patency rate is low. 50% is the 10-year patency rate. And we know that PCI, there's a low restenosis rate in PCI, but we know also that PCI carries those who have multiple PCI, as compared to CABG, they have higher rate of revascularization. So these are facts. What's the definition of hybrid coronary revascularization? It's a planned or intended combination of consecutive CABG surgery using at least one internal memory artery to the LAD and catheter-based coronary intervention to the non-LAD vessels for the treatment of multivessel disease. So it's a planned, intended procedure. It's not that, let's say you do a PCI and a patient presents with STEMI, and then if he develops LAD lesion later on, you put LIMA on LAD, and that's not counted as HCR. So it's a planned procedure. The benefit is the benefit that applies to all minimally invasive surgery, non-sternotomy, no coronary bypass surgery, pulmonary bypass machine. So it carries less pain, faster recovery, less bleeding and need for transfusion, lower organ dysfunction, and early return to activity and work. That may be not so important in our side of the world. People look for sick leaves, of course. The challenges here of applying HCR in every case is that we don't have evidence to support HCR. So we have limited evidence of the safety, effectiveness, and long-term outcome of HCR. The learning curve, PCI, I think it's well established, but learning curve of mini thoracotomy and beating heart or on pump, so that also requires a higher skill sets. Adoption by surgeons. Not every surgeon, most of the surgeons, in fact, feel comfortable with conventional CABG and do not want to change. And that's why, in fact, we lost the chance of developing robotic and maybe endoscopic not, but the robotic utilization in cardiac surgery. We lost it, and we're behind because surgeons did not adopt robotic surgery. And of course, cardiologist referral. They try to let's say do all the cases, and they rarely refer single vessel disease or even multi-vessel disease that are good for HCR. So the evidence, unfortunately, it's in 2018, it was classed as 2B evidence. So it's not, you could consider HCR. In 2021 coronary revascularization guidelines, there was no sufficient data to recommend it. So they did not have a recommendation. There was, in fact, an attempt to have a randomized controlled trial comparing HCR to multiple PCI, but unfortunately it was terminated prematurely because of low enrollment. There's only one, probably two randomized trials, but these are small trials. This trial proved that 5-year all-cause mortality when compared with conventional bypass surgery were similar. This trial, it's a one-stop HCR, proved to provide favorable midterm outcome for selected patients, and even higher risk cases, it proved to be beneficial. This was a Chinese study. But on the other hand, this study, in fact, states that the hybrid coronary revascularization may be a valid alternative to multivessel disease, demonstrating a lower incidence of MI and target vessel revascularization. It depends on the center experience, of course, and patient selection. Again, patient selection is very important in those cases. This is a registry in New York. It proved the contrary, in fact. It says that HCR has a higher rate of mortality at 1 year and higher rates of subsequent revascularization, including also LIMA to LAD. And those patients who had HCR, LIMA to LAD did worse than the conventional. Most of the studies that were published were meta-analysis of retrospective or observational studies. And they all proved that at least they're similar when compared to CABG, conventional CABG, they're similar in terms of mortality and survival. The advantage is like any advantage of minimally invasive, lower blood loss and required for transfusion, shorter hospital stay and return to work, and less kidney injury. But the disadvantages, most of these are done either endoscopically or robotically, harvesting the LIMA. And it's more expensive when you count only or consider the procedure. And the requirement for repeat revascularization. So it's good, but at the expense of repeat revascularization. And this is, in fact, it's a position paper of the European Society of Cardiology. It states that the benefit of CABG over PCR for revascularization of non-LAD vessels based on the patient's clinical status and presentation still is ambiguous. It can be performed by a dedicated team. It should be, every case should be discussed in a heart team. The surgical technique, LIMA harvesting, either direct vision or endoscopically, and the incision either mid-cap or lower sternotomy, and you either use a heart-lung machine or not. And these are the sequence of HCR, either you do the surgical part before or after PCI, depending on the culprit lesion, and either one-stop shop, as they call it. You do it in the same setting or within the same admission, or even later on. So there's no consensus on how to do it. It all depends on the culprit lesion. Who may benefit from HCR? I think PCI to non-LAD culprit lesion, followed by LIMA to LAD for complex LAD lesions. And complex LAD lesions, we know that LIMA is better than PCI. So if the cardiologists leave those cases for us, they may benefit. High-risk cases, as minimally invasive surgery, it's probably better for them. And young patients who probably have complex lesions in the LAD and still LIMA is better, we could do that. And then even if they require conventional CABG in the future, you have a fresh sternotomy. Well, this is one of the cases that had occluded LAD and diseased RCA. He had stents. I'm sorry, where is it? Yeah. He had stent to the RCA, and then following a few days later, he had LIMA to LAD. And this is another case this patient, in fact, can I just have 30 seconds? As the president of the society.
Give him 1 minute. Double what he asked for.
Shukran, Qasim. You'll become the president next. Anyway, this patient had presented with non-STEMI, and he had RCA diffuse disease and included LAE. In fact, he was referred to conventional cabbage, but he was obese, smoker, diabetic, hypertensive. We discussed them in the heart team. We decided because of his comorbidities, probably hybrid is a good option. So we did the Lima to LAD, and then he was discharged, in fact, and was readmitted, I think a month or two later on. His RCA, in fact, progressed rapidly. So he had stent to the right, and the Lima was patent. And also he had stent to the circ. So this is another sub. Anyway, the conclusion is that cases should be selected. You need to have expert surgeons to do this. In selected cases, it has good outcome. With, of course, cautiously, probably they may require a higher rate of revascularization. Thank you so much.